entitled COVID. Welcome. Good evening. My name is Winston Wong. I'm a family physician. I'm also the chairperson of the National Council of Asian Pacific Islander Physicians. And I want to thank you for joining us in a very important and stimulating discussion, we certainly hope, in the next hour or so, entitled COVID in People of Color. This particular webinar follows a webinar that was similarly formatted a week ago by the National Medical Association. We want to thank the National Medical Association for bringing our great group of panelists together, since this is going to cover the broad spectrum of diverse populations in the United States. As all of you know, today in the United States, we are facing our darkest moment in public health in our generation. 14 million Americans have been infected and 273,000 Americans have died as of today. A sobering statistic, and even more sobering given the fact that the majority of deaths have occurred in communities of color, and certainly marginalized populations, and populations that have historically been left out with regards to quality healthcare and public health actions that really address issues like our pandemic. I want to mention that this particular webinar has also been supported by the Cobb Institute, a portion of the National Medical Association, and also is supported by the COVID-19 Prevention Network. So we want to thank those organizations for bringing us together. I also should mention that I am part of the Alliance of Multicultural Physicians. The Alliance of Multicultural Physicians was put together about 3 years ago to provide a collective voice for the number of really important minority physician organizations across the country, notably the National Medical Association, the National Hispanic Association, the Association of American Indian Physicians, the Association of Black Cardiologists, and the organization I referenced earlier, the National Council of Asian Pacific Islander Physicians. Last week, the Alliance of Multicultural Physicians met very quickly to put this particular panel together. And we all agreed that the panelists we have today represent some of the best partners and individuals that are working with our various communities to make sure that there is diversity in clinical trials pertaining to the COVID-19 vaccine, as well as individuals that have been leaders in reaching out to communities to make sure prevention efforts, vaccination efforts, and public health efforts meet every member of our communities. So with that, we're going to get into this discussion, and then we really framed this discussion to speak to physicians. We think the majority of you today, this evening, are physicians, clinicians that are at the front lines of caring for our diverse communities, and we might have a very frank and candid discussion about those issues with regards to the COVID-19 efforts, and particularly with regards to being really right around the curve in terms of vaccination efforts. To that end, we hope to engage every one of our panelists in their observations, their remarks, their perceptions, and advice with regards to the great undertaking that is in front of us. Also, we invite you to use the Facebook system to feed in some of the questions. We'll have some time at the end for questions and answers that you initiate through the Facebook foundation setup. So with that, I want to introduce our speakers, and I know we've been working in real time, and some of our speakers were just still logging in, so I just want to make sure that we got everyone here. First, I want to mention our first panelist I want to introduce is Michelle Andrzejczyk, PhD, Director of Social and Behavioral Sciences and Community Engagement. She's with the COVID-19 Prevention Network. And Dr. Andrzejczyk has done a considerable amount of work out of New York City in terms of HIV education and outreach. And she's a leader in terms of working with that have been marginalized. I'll get back to you in a moment, Dr. We also have Dr. Lonnie Nelson, PhD, Assistant Professor, Department of Nursing at Washington State University. Dr. Nelson is with the Eastern Band of the Cherokee Nation. Dr. Nelson has extensive clinical and research experience in neurocognitive assessment and in rehabilitation interventions for people with brain injury. And as American Indian origins in the Eastern Band of Cherokee Indians, he's been engaged in research, education, and training to improve the health and well-being of Native Americans. So thank you, Dr. Nelson. We also have Dr. Alka Kanaya, who is a professor of medicine, epidemiology, and biostatistics at the University of California, San Francisco. Dr. Kanaya is a professor of medicine, and she focuses on type 2 diabetes, obesity, and vascular disease. She has been the principal investigator of the MASAL study that was funded by NIH to determine risk factors for subclinical atherosclerosis among South Asian Americans. So thank you, Dr. Kanaya, for joining us tonight. We also will have Dr. Fabian Sandoval, who is the CEO and research director of his particular organization, which has spent over 25 years in terms of reaching out to communities and connecting bedside research to communities. His diversified research career has been in academia, healthcare systems, and the public sector, and he has been done significant work in early onset Alzheimer's disease and Creutzfeldt-Jakob disease. So thank you, Dr. Sandoval. We also have Dr. Reed Tuckson, and many of you know Dr. Tuckson. He's had a decades of experience in leadership throughout our public health community and in minority communities. Dr. Tuckson is the managing director of Tuckson Health Connections, LLC, a health and medical care consulting business that brings people and ideas together to promote optimal health outcomes and value through innovation and integration across the fields of prevention, public health, consumer activation, quality care delivery, and the translation of science. Dr. Tuckson is currently president of the American Telemedicine Association. He's also serves on the National Advisory Council for Complementary and Integrative Health of the National Institutes of Health, and has a number of prestigious previous appointments. And I don't know if you remember Dr. Tuckson, but you also chaired a committee on TB elimination, which I was honored to be part of many years ago. So we have this great group of panelists, and I actually wanted to start off with Dr. Andrzejczyk, Michelle, since I believe you were part of the webinar last week, and I know that the COVID Prevention Network has taken a broad-based perspective on what efforts really need to be launched given where we are with the vaccine and also the amount of hesitancy and gaps in trust that we have across our communities. Can you provide us a little bit with an overview of where the COVID-19 Prevention Network is seeing where our greatest challenges are in terms of reaching out to our various diverse minority communities?
Thank you, and thanks for having me on this panel. Really appreciate the invitation and the opportunity to share our work. So the CoVPN has been working to really address uncertainty and fear since the very beginning. And I think what is key in our understanding is that uncertainty and fear has shifted as new information has come out, and you know, as the political climate and the information about COVID and the vaccine trials have emerged. So early on, we were really focusing on the fear and uncertainty around the perceived speed of the vaccine trials, and certainly the name Operation Warp Speed did not engender this feeling of caution and safety. So really educating everyone around what steps can be taken to expedite trials, clinical trials, in this case specifically vaccine trials. Also, there was concern around targeting specific populations, and we really wanted to communicate why we had priority populations and ensuring that people understood some of the long-standing social, structural, and economic factors that have placed communities, particularly communities of color, at differential risk, and some of the underlying reasons why we're seeing the disparities that we see in COVID and with so many other disease outcomes. So we've done quite a bit to make sure that we have materials available and that we are partnering with trusted voices. This is a great example of how we have partnered with multiple institutions and to get the word out. And we've been doing that throughout. And by we, I mean the larger CoVPN. And we, even within our organization, we have a partnership between external relations and community engagement and the communications and marketing team to really move these efforts forward and ensure that not only are we partnering with grassroots organizations and people doing the work at the ground level, but also national organizations who have great communication channels and can really ensure that the resources and information are getting into communities so that people have the tools that they need to make informed decisions, not only about whether or not they're going to participate in these clinical trials, but when a vaccine or therapeutics are readily available, they can make informed decisions about what they can do or what they can do for their families and their larger community.
Thank you, Dr. Andrzejczyk. It's very interesting. I think today the news suggested that President Bush, President Obama, and President Clinton might actually go on TV as individuals that will take the vaccine to encourage hesitant individuals to take the vaccine and to assure that it's safe. Do you have a perspective on what physicians can do to also make the case that the vaccine will be effective and safe?
Mhm. Yeah, well, certainly, I think underscoring the safety mechanisms that we have in place, and that's something that we have really tried to disseminate out into the public. We have a website and we've created a Dropbox with materials that talk about safety and talk about the various mechanisms in place. One example of this is the safety pauses. We recently developed an infographic on safety pauses, underscoring how this is actually a good sign that the safety mechanisms that are in place are working and moving the science forward in a way that ensures participant safety, and not only participant safety, but safety for the general public. So I think as much as physicians can familiarize themselves with the safety mechanisms that are in place and, ensure that their general uh, population and their patients understand the safety protocols that are in place. I think, the better acceptability and uptake we'll see down the line.
Thanks, Michelle. I think, just to reference my opening remarks with regards to the Alliance of Multicultural Physicians, it's been our argument that physicians really are a real mainstay with regards to providing that kind of effective communication that sense of confidence that our patients need is not necessarily just going to be coming from CDC making an announcement, but it's about those trusted physicians that are practicing every day in our communities.
Yeah.
Uh, Dr. Tuxen, I know that you've been, at the forefront of these challenges for all of your career. Though COVID-19 is one of the most, challenging, uh, one of the biggest challenges we've had in our lifetime. Can you kind of extract what do you think are the unique challenges with regards to this pandemic and how we build trust in our communities?
Thank you
The
very
mic,
much.
yeah.
That it is an absolute joy to be working with you, and I appreciate your leadership over the years, and I'm glad to see you're continuing to be a leader even now. I think that what makes this pandemic so challenging are a couple of the confluence of multiple factors. Number one has been that we live in a society now that is so highly polarized, and where there is no or a extraordinary erosion in the trust of government, erosion of trust in elites, erosion of trust in health professionals. That erosion of trust is being magnified every day with a extraordinary prevalence of our social media that is unregulated, unruled, no true north, no place to go for any sense of editorialism around the information that's presented. And so combining distrust with a plethora of misinformation, and then the politicization of this pandemic by an absolutely disreputable president of the United States has certainly certainly exacerbated these issues. On top of all of that, the contemporary issues, of course, are the historical issues where people of color and marginalized populations have been treated with such disrespect, with such lies, with such poor treatment over the years, and those memories remain. Those memories not only remain, but have been inflamed by current events. So adding all of that, and then finally into this toxic brew, as you well know, we have a disease where so many of the people who are spreading it are asymptomatic without any signs or symptoms that there may be something wrong with them. And that finally, we live in a society contemporaneously where individuals seem to be much more interested in their own personal rights versus any sense of an ethical or moral relationship to each other. Now, to quickly respond and give others a chance to get into this conversation, you asked, what can we do? As health professionals of color, our first responsibility is to be able to let our patients and our communities know we care about them, that we love them, that they are important to us, and that we're coming at our work from a position of love, empathy, and compassion. That is very important. Number two, there has to be a trusted voice. And so our organizations have to be the ones that are speaking to our community with accountability, being honest about what we know and honest about what we don't know, being a trusted resource. And then third and finally, we have to be the ones who are able to present complex information in an understandable way, but information that is exquisitely based on facts and on science. I would finally augment our first, Michelle's comments at the beginning by also indicating that it is important that we as health professionals of color are deeply involved in the IRBs that are looking and regulating and commenting on these clinical trials and making sure that our faces as participants in those IRBs that are overseeing the ethics of those clinical trials, that it is being viewed and seen transparently so that they will know that the conduct of this research is being monitored very carefully by people who love them, who are accountable to them, and whom they can trust.
Thank you, Dr. Tuxen, for those really insightful remarks. I've been told that my voice or my sound was a little bit low. I apologize for that. I'll try to speak as loudly as I can and in the microphone. But I did want to now turn to Dr. Kanaya as I mentioned years of work in South Asia. Some of the statistics with regards to COVID-19 and Asian Americans and Pacific Islanders and Native Hawaiians is not as well known with regards to the burden of disease as we see in the Hispanic community, Latinx community, and in the Black community. I was wondering, Dr. Kanaya, if you could just touch upon that and also give some insights in terms of what are some of the special challenges with regards to COVID-19 outreach in that community.
Yes, thank you so much for including me in this really informative session. So I think the challenges are that Asian American, Native Hawaiians, and Pacific Islanders are kind of silent in terms of the data here in this epidemic. We have pretty good data reporting by states, but it's not available nationally, and not all states have this data. So when we do have data on Asian Americans and Pacific Islanders, it's generally grouped together or it's put into an other category, which makes it really difficult to look at the prevalence or the incidence of COVID and the complications of COVID. So I do want to point out that one of the best done studies with over 50 million patients who it was done by Kaiser Family Foundation, and they looked at people who were getting care in organizations that use the Epic electronic health record, and they looked at 50 million patient data, and they were able to disaggregate into 4 large race ethnic groups: white, African American, Hispanic/Latino, and Asian American. And what they found was that Asian Americans were less likely to be tested for COVID. And when they were tested, they were more likely to have positive results. And they were more likely to be diagnosed when they were later in the course of their disease or had more severe disease, and more likely to be hospitalized for COVID, and more likely to die. And when you adjust for sociodemographic factors as well as for other measures of deprivation, Asian Americans actually had the highest hospitalization rates as well as highest death rates of COVID compared to all of the other 3 major ethnic groups. And this is data from, again, 50 million patients. And I don't think that this has entered the national conversation. And why is that? And what are the barriers? I think, many barriers to data reporting, but why is it that Asian Americans may be getting tested at lower rates? I think there's, again, like Dr. Tuxson said, there's historical reasons for possibly having less trust, but also, with the way this epidemic or pandemic has been politicized, as well as our president calling the virus the China virus, has not helped in terms of the racism and xenophobia that a lot of Asian Americans, especially East Asians, have encountered and faced, and the reality of the fear of being targeted when you go get COVID tested. And so that is another major setback that we've had in terms of working with communities that are Asian American.
Thank you for that overview. And just to keep on that thread, Dr. Kanaya, could you speak about any aspects of immigration status that might also complicate outreach, screening, and treatment?
Yes, of course. Yeah, I mean, people who may be immigrants who are undocumented for obvious reasons are going to fear coming for help when they need it. Also, immigrants who are documented and have green cards are waiting for their green card, or are on visas, legally here on visas, but don't have their green cards yet, are going to fear potentially being targeted with public charge type of rules that would, if they required care in the public sector, and they would that would make them more hesitant to come forward, to be tested, to be treated, to be cared for in healthcare settings. So these are real fears that I think we have to acknowledge. We have to do more to reach out to communities that have been, facing these real concerns, to make sure that they are getting the care that they need, they're getting the information that they need, that we can allay some of the fears and some of the disinformation.
I'm not sure if we're getting any canine response, but anyway. Uh, Dr. Andrzejczyk, you touched upon this when we kicked off the discussion, and it's really about the historical context of structural racism. And certainly, as far as the Black community, much has been said about Tuskegee, um, the various public health errors and intentional ways of reinforcing kind of racist practices. Can you give us some insight as to how we talk to communities about the legacy of racism in public health, but how to overcome those fears given that we're at such a critical path in our battle against COVID-19?
Well, I think all of our communities carry with us a legacy of racism that has denied all of us at one point in history education, housing, employment. And what that has resulted in today with COVID is that more of our community members are living in poverty. More of our communities members find themselves in employment where they don't have the privilege to work from home, and as such have to show up to places that put them at risk for possible exposure to COVID. And when they are exposed to COVID, these same factors have been implicated in underlying pre-existing medical conditions that place them at exponential risk for severe disease progression, hospitalization, and mortality. So I think we have to acknowledge that, and we have to look at the situations and circumstances that have put us in this place and ensure that our voices are at the table and that our communities have the resources that they need to be able to effectively combat this and ensure the health and well-being of all of the members of our community. And that means that we need to ensure that when we have vaccines and we have therapeutics, that they are available to us, that we are informed consumers, and that we have been involved in the process and are in line for these therapeutic and vaccine products. And as we roll out vaccines and we see the emergency use authorization, which will come out before Christmas, the first phase will be for individuals who are essential workers and who are in congregate living facilities. And we are, very, overrepresented in those who are at higher exposure. So I think it is really important that we ensure that our states, who will be responsible for rolling out these plans, have clear directives in place and clear strategies in place to ensure that our communities are equitably receiving these therapeutics and vaccines as they roll out. I think that is really critically important, that we're at the table, that our voices are heard, and that we ensure that we are receiving an equitable distribution.
Winston, if I could augment that, if I could, I think this is such an important point that Michelle makes. In addition to what she's saying, I think that we need, as leaders of the Native American community, as leaders of the Latino community, and all of us, we need to be able to have a roster of our faces in all of these places, from where we are leading at NIH, where we are in the FDA, where we are in state and local government, and as Michelle indicated, they're in local communities. And I think that our obligation at this moment is to speak, once we compile all these offices of minority health that exist all around this country at the state, local level, as well as every one of these federal government agencies. I am really hoping that this is the historical moment where they put together a collective list of people of color who are in positions of authority, so that we will be able to communicate those faces and names to our constituencies. But secondly, what comes out of that, Winston, is that where that story is suboptimal and where that story is not a robust story in terms of being inside the tent for where the decisions are made, then we need now to call the question. And we should come together, all of us, with a united voice that says there is no way going forward that we will be able to convince our community to participate in the things that will save their lives unless we have people in these positions of authority. And so I think this is a very important moment, and I think one that we need to drive through and cause change. And I'll conclude that by saying that it is amazing to me in the African American community that in 1980, when we were fighting the HIV epidemic, and I was the Commissioner of Health and privileged to be so in DC at that time, the Tuskegee syphilis experiment was prominent as a rate limiting step to getting people to do the right things. How could it possibly be that in 2020, I am still fighting that same battle and that Tuskegee is still rearing its ugly head? There has been almost nothing that has been done in the intervening years to increase the confidence that people have in the integrity of our health enterprise. And so I just hope that we will all come together now and make this a cause celeb that unites all health professionals of color as we compile this list, make this list available, analyze that list. Where it is suboptimal, it is time now for people to put us in those positions so that we will be able to speak to our community and save our community's lives.
Thanks again, Dr. Tuckson. You always provide such inspirational words, and it reminds me too, with regards to how we represent ourselves, because we here, and we're not having our Dr. Sandoval and our Native American speaker yet, but I know that actually in all our communities and wherever we practice, we're not seeing exclusively just Black patients. We're not seeing exclusively Asian patients. We're not seeing exclusively Latinx patients. We're seeing the cross-section of Americans and a cross-section of diverse populations. And we need to be able to show a united front of different physicians from different backgrounds, reassuring our communities how important we need to take our responsibility and accountability of protecting our communities. I've been informed most recently, by our Native American brothers and sisters about the complexities of their sovereignty as individual nations and how they have to negotiate relative to the vaccine allocation as nations, as opposed to, communities where a lot of our other populations are. And those challenges have to be addressed in order to really meet that head on, because we know the Native American Navajo communities, the Cherokee Nation, has been devastated by COVID-19, as they were devastated by the flu back in 1918. So this is not something that is actually new to the Native American community, and it behooves the American government to establish those agreements so that the national sovereignty of the recognized tribes is really put in place, so we do the most we can for every community. Certainly in terms of the Latinx, yes, the Latinx community here in California, it was mentioned today for one of our communities that there are a large segment of workers that are not with, they don't carry around a social security number. They're available to do a lot of the odd jobs that our communities rely on. And we have to reach out to those communities that don't have a regular point of access for primary care, that don't know how to navigate the system, and don't assume that all those folks speak Spanish, because they speak a number of different languages, dozens of different languages representing the Central and South American nations in which they immigrated from. So we have a lot of things to consider in terms of building that trust and outreach. So Dr. Andrzejczyk, did you want to weigh in a little bit more on this topic?
Yeah, and this really builds on what you were saying and what Reed was saying, in terms of really utilizing the trusted voices and the leaders in our communities. The work that has been done with tribal nations in Alaska. Dr. Denise Dillard has really been working to ensure that the steps are taking to ensure tribal and data sovereignty, and Dr. Bonnie Duran here in Seattle has been doing that same thing with the Lumi Nation. And it really, will require trusted voices and people within our communities who are the experts and who have the experience to carry this forward, and who have not only been working with communities but within communities for the vast majority of their career. And I think those individuals are real leaders and can help you know continue to fortify the bridges that have already been built and build new bridges to ensure that our communities get the services that they require. And the other thing I would mention are, the vast efforts that are currently underway by institutions like the Mexican consulate, who are integrating some of these messages in their ventanillas de salud, and the work that's been done by blackdoctors.org, Unidos US. And again, a lot of this is working together to ensure that we're pooling resources and building our collective capacity to get the information out and to ensure that our communities have the resources that they need to move forward. And I think a really great example of this with their Ventanillas de Salud program, the Mexican consulate has been working really closely with our organization to ensure that they're getting factual information out into communities. And they not only work with Mexican American individuals, but people across the Latin diaspora. And I think that's really critical to utilize those trusted voices and those channels of communication to ensure that our communities have what they need.
Dr. Kanaya, I know you have had a lot of experience in terms of engaging different communities that historically have not been part of clinical trials or research. I was wondering if you could draw from that particular experience and maybe suggest some concrete actions that we could do at this juncture in terms of doing the right kind of COVID-19 outreach and vaccination outreach.
Yeah, no, I want to second some of the champions that Michelle and Reed have been talking about in terms of having community champions, as well as having community physicians who have been working in the community settings be, the voices that people trust to help build overall trust in the vaccine and in the rollout of the vaccine. Yes, it is incredibly difficult for us to have more representation of Asian American Pacific Islanders in trials. And I think a lot of the people I've talked to in the community have said that. It's like, well, I look at Pfizer and the Pfizer vaccine, they don't even report, at least in the press release, what racial ethnic minority groups they have. We know Moderna has at least, 40%. People of color in the trial, and we really were waiting for the data to see if there was any differences. They said in their press release there weren't differences by race ethnic group in terms of vaccine efficacy. There were similar numbers of people who got COVID in the placebo arms of different race ethnic minority groups. So there is at least some effort to enroll a diverse population in the Moderna study. But I think our communities are going to need to see this, and we need to be very clear that yes, we do have some level of representation in these studies, and that we can trust the data will apply to our communities as well.
I think you touched upon the transparency aspect of how transparent the clinical trials have been with regards to including our diverse populations. Reed, you've done so much work in HIV as well, particularly with regards to new therapies. We actually have a question that I want to kind of uh, just summarize a little bit here, is that the new vaccines are using novel therapies, and in fact, too, the project has been termed warp speed. Is this complicating the message with regards to the amount of confidence our communities can have in the vaccine?
It is very definitely complicating it, extremely so. But also, what is complicating it is an abject failure on the part of our federal leaders to explain how these vaccines have been developed and why they have been developed so quickly. And also, what's complicating it is that people believe somehow that, at least in the United States, that somehow it's the United States scientists trying to do something to marginalized populations. And so very briefly, what we have to remember to teach our patients is that the reason that these vaccines have been developed so rapidly is because we had a very big head start. Coming out of the experience with the Ebola outbreak, we learned some very important lessons about how we needed to be prepared so that we could react in time. We were very lucky that we were able to develop a prototype of the vaccine based upon some important work that had been done in chimpanzees. And we were able then to engineer a central piece of information that could be programmed to do many different, react to many different kinds of viruses fairly quickly based upon this one novel, very smart instrument that we had. Secondly, we have to remember and teach our patients that we had a very nice head start based upon this kind of technology. And then we need to help them to understand that from the very first patient reports coming out of China, very early on New Year's Day, we were able to see that what this virus was, and begin to understand it genetically. And then finally, we were very fortunate that the virus is a coronavirus that we knew a lot about already because of SARS and because of MERS. And so we learned quickly that the spike protein that was the Achilles heel of this virus could be programmed against and have early identification. So all of these phenomena all work together, but we did not start from a standing start with the first cases. This was the benefit of pre-thought out work with pre-developed tools and instruments that could be then quickly applied to this particular phenomenon. And then the last point that I would urge our health professionals on the call to not only make sure you know and understand that story as you talk to your patients, but it is also, as we talk to people and patients in the United States, to know that it is not just work done in the United States. This work was done in Germany, in England, in China. Many other countries have all been contributing to the fund of knowledge that is leading us to this. And so those who feel that this is a Donald Trump inflicted opportunity are very narrow in their understanding of really what's happening in science, and how what we're benefiting from is actually technology and ideas that have been developed all around the world. So if we can do a better job of explaining to people the process that led us here, they wouldn't continue, hopefully, to fall prey to these conspiracy theories that make it seem as if it would have been humanly impossible for human beings to have developed a vaccine to this virus in the speed with which we have been able to do. This should be celebrated as an extraordinary human achievement that rivals some of the greatest advances that we've ever seen in the history of the world, as opposed to looking at this as some dastardly deed being inflicted upon us by pernicious people.
Fascinating. Michelle, I was wondering too, given that narrative, we have a spectrum of hesitators, so to speak, those that maybe, pretty college educated, very secure in their sense of science, even, who may be hesitating. On the other hand, we may have folks that are not as well educated or is not as health literate. Do you have any perceptions about how do we modulate our messaging for different uh, uh, backgrounds, social understandings of the healthcare system? Any advice?
Well, I think we have to be incredibly transparent. And, one of the lessons or perhaps, aha moments that has really presented itself since the efficacy results were first published is the numerous emails that I've received that have indicated that there is a real lack of understanding and real confusion around what those efficacy results mean. So I think we have to be really clear in how we communicate the data as it rolls out. And we're getting new press releases constantly. And so I think, it really, again, is important for us to ensure that the way we're communicating is transparent and clear. For example, the 90 to 95% efficacy that we've seen is in the prevention of severe disease progression, and that we don't have the data right now to say with any certainty if that is the prevention of infection of SARS-CoV-2. A really important point, and one that I feel is lost on a lot of individuals. And the same level of nuanced detail will be needed when we see the executive use authorization. Why are the decisions for dissemination being made in phase 1? What are the driving factors for that? And if we do have a vaccine now that is prevention severe disease progression, hospitalization, mortality, how is that impacting the decisions for rollout? And I think that those are critical, nuanced points that we need to be very clear of when we're moving forward, so that people don't hear something and then later on feel as though they might have been duped, or that we didn't tell them the full story, because we forgot or neglected to focus on the details that may be missed. Because a lot of the news is saying, 90 to 95% efficacy in the prevention of COVID disease, which is true. That's technically accurate. And what we're finding is that people are reading that to be prevention of infection, and really critical distinction between the two, and one that I think could potentially lead to more uncertainty, more fear. So transparency and attention to detail is really, really critical. And again, making sure that trusted voices are involved in communicating that message and are at the table when making decisions about what that communication needs to be and how it needs to roll out. I think that those are all critical points.
So what I'm going to do now is I'm going to put all of you a little bit on the spot, but I think this might be effective, as well as maybe will be something that our listeners can really use. I wanted to see if Dr. Kanai can start the ball rolling in terms of, let's imagine you're speaking to a patient who's really unsure about the vaccine. Can you open up the kinds of conversation and dialogue, and then pass the ball to Reed to see if he can build on it? And then Michelle, you can kind of put the bow on that. We can keep it going if we think that we need to add on, because I think these are the real discussions that we have to have with our patients and with our communities at large. So Dr. Kanai, do you want to start the ball going in terms of how do you start this discussion about COVID-19, the vaccine? Is it effective? Well, am I going to get an adverse effect, and why should I believe you? How would you start that?
Yeah, no, great question. And so I've been thinking a little bit about this because I've been getting these questions from patients already. And I will tell you that I start from a place of here's what we know and here's what we don't know about the vaccine. And really, again, transparency. As Michelle said, we know that these 2 mRNA vaccines that look like they're going to be approved pretty quickly have really good efficacy data for those with symptomatic disease. People weren't being tested every week in these trials, so we don't know about the people with asymptomatic disease or with mild disease that they didn't bother to report their symptoms or get tested. So what we know is that these vaccines appear to be extremely effective in prevention of more severe disease, of hospitalizations and mortality. And that's why we recommend taking it. And I think part of it is being open about my own feelings about the vaccine with patients that I know in my primary care clinic, that I am going to be first in line when my number gets called, that my phase 1A, 1B, 1C, whatever phase I'm in my medical center, I am taking the vaccine. I am doing it. All of my colleagues, my nurse practitioners and doctors will be taking the vaccine. And I think showing that even though we don't have all of the information, that we have enough good information that matters, that makes me trust in the vaccine and get the ball rolling that way.
Okay, so Dr. Kanaya started the ball going, Reed, and she's basically said to her patients,
everything that needs to be said.
Yeah. Well, maybe not.
Let me play with it a little bit.
She's bring you in. Dr. Tuckson's going to tell you a little bit more about this vaccine. I'm still hesitating. I'm still on the fence.
Well, first of all, I would start though. All joking aside, Winston, I would start sort of where Alka did, is to say first, Mrs. Jones, I have enjoyed my relationship with you as your physician for a long time. I have listened carefully to you about your values, your concerns. I understand that you have a family. I know what you are, that you fear for the health of your children. I'm also aware that you visit your elderly parents on a regular basis, or you would have liked to and you can't anymore. And that family means everything to you, doesn't it, Mrs. Jones? You've taught me that a lot. So I've listened to you and I understand where you are. Previous to my getting ready to make these comments to you, Mrs. Jones, is that you've shared with me some of your fears, what you are worried about. And I've listened to those very carefully. Let me explain a couple of things about that. I understand that you have had people in your community who say that this is not safe and that this is a conspiracy to do damage to you. Well, I'm in a position to tell you that I have had an opportunity to review the data myself. And I'm pretty good at reading the science literature, and I've seen very carefully what's come out. Not the press releases from the drug company, but I've read the actual material that came out of the special committee that has reviewed this, and it went to the FDA. But as good as I am, Mrs. Jones, there are people that are better than me who I trust. And let me tell you who that person is. And that person's name is Dr. James Hildreth, and he is the president of Meharry Medical College. And he's one of the people that I turn to for advice. He's a person of color. And he has great values. And this is what he told me after he reviewed it and why he decided that this was a good vaccine to take. I also want to tell you that that if we decide that we don't want to do this, let's talk about what that means for you and your family. Now, I know how much you care about education for your child. But, if we don't get this disease under control, we won't be having school. And your child will be left behind, while the other communities that seem to trust this more, their community schools will be open. I know you also want your husband, who works in a small business in the community, to be able to go back to work. But those small businesses won't be able to open up if we don't get control over this. And lastly, I know you're wearing your mask and you'd like to have some time where that's not going to be the case. Well, even with this vaccine, you're going to be wearing it for a short while longer. But at the end of the day, if we can get enough people like you to wear that mask, then we have a chance and to get the vaccine. Then before too long, we'll get to a place where we get the 200 million Americans who either have had the disease or have been vaccinated, and we can call this game over. So that's what this is really all about. And I also want to ask one last thing. As we go forward, and if you still haven't satisfied you and you have more questions, I want you to know that I'm here for you anytime you need. And I'm welcoming your questions and your insecurity and your uncertainty. But I think at some point, just like I'm taking it myself, like my good friend, Dr. Kanya is taking hers, I'm going to let you know that I'll be here to help you to make that decision in the days to come if you decide not to make it today.
So I'm still that Dr. Tuxen. That was really convincing. But I tell me, if you have another colleague, Dr. Andrzejczyk, could give me a sense of what this means for my neighborhood, for my communities. I'm not sure if I want to do this.
Well, full disclosure, I'm a clinical health psychologist, so much of what I would do would be starting from a place of warmth and acceptance, and really listening to what the person's concerns and fears are, and asking open-ended questions to try to understand what is going on with them and why they have reached the decision that they are currently in. And really using reflective listening skills to try to understand what this means to them, what this means to their family, what this means for them and their larger community, checking in with them rather than assuming that I know what is meant, and really making sure that we're on the same page, and importantly, affirming their perspective, affirming their beliefs and their fears and their concerns, and normalizing that. You're not the only patient that I've seen who has these concerns, who has these fears, and and really making sure that people are affirmed in how they're presenting, and then ensuring that I give them the information that I have in an open and respectful way, and really addressing some of their concerns, and making sure that I'm addressing it again in a way that's not judgmental, that's not putting them on the defensive, and ensuring that we're working through this together as a team. And how can I give you information and help you make an informed decision. So that would be the approach that I would take as a clinical psychologist.
I guess you have an advantage. We have a question from one of our audience, which I'll wrap into just continuing this ball of discussion. And so I'm going to paraphrase a little bit this question that comes from Anuka Thomas. So Dr. Kanaya, you're telling me to take this vaccine, but there's like 2 or 3. I heard there's 4 or 5. Why should I take this one? One says it's 90% effective. Another one says 90. Are you just using the one that's convenient for you? Why should I do this one? Shouldn't I wait until the best one comes out?
Yeah. No, I think that's a really good question. And that's a question that a lot of people are asking right now. The ones who are, getting the first doses delivered to the hospitals is, should we be waiting for the next one or the third one or the fourth one? We don't have all the answers here, like which one is better, because they haven't been researched, one against the other. We know about each one being safe and effective. And other vaccines that we use and we take on a yearly basis, like the flu vaccine, is at best 50% effective. So we are lucky enough to be able to have 2 to 3 vaccines that are above 70%, 80%, 90% effective. And a difference between 90 and 95 is really meaningless. And it just means that these are good vaccines in terms of the prevention of the severe diseases. I think there are real, concerns about the different technologies that were used in the mRNA versus the Oxford vaccine using, the chimp adenovirus vector to deliver the DNA for the spike protein versus the other technologies and the ones that haven't yet reported their efficacy data. And I think time will tell us, if there are any differences at all. But right now, I guess we don't have enough time to waste in terms of the numbers of people being infected and the numbers of people dying every day to start vaccinating people based on these 6 months long data that we have that prove that these vaccines are safe and effective.
And may I add to that?
Yeah,
May I add a piece of that? I mean, the reality is that we're not going to have enough vaccine in this first phase anyway. We maybe have 40 million doses to roll out this first phase in the face of an emergency use authorization. So, by the time the manufacturing, I mean, this, as my panelists have stated, is unprecedented, the speed at which we have reached a vaccine that has this much efficacy in the prevention of severe disease. And by the time the manufacturing catches up to the pace of science, we'll have a lot more data and people can make more informed choices. But in this initial rollout for the EUA, we're talking 40 million doses. So I think, vaccine scarcity has to be part of the conversation as well.
And by the way, when we mention 40 million doses, we're talking 20 million people because it's 2 doses each. So in other words, it's only 20 million people actually that will be in that first tranche.
So I do want to raise another point if I can, Winston. I don't know if I'm going to derail you here, but I think the other part of, educating, informing, and doing the outreach to our patients and communities is to let them know that once you get the vaccine and both doses of the vaccine, you're not home free, because we still need to do all of the things we're doing in terms of masking, social distancing, and, trying to be careful, because we can still spread disease and we just don't know how much. And there's going to be so many more vulnerable people who haven't had the vaccine that we have to care about. And that's a part of the conversation that we haven't talked about yet, but I really do think it's important to bring up.
Yeah, that's great, Alka. I actually wanted to make sure we built the ball here. And if any of you wanted to add a little bit more to the conversation we have with patients, I'll entertain them right now. Otherwise, I'll start a new ball. Okay, the new ball is we've been talking on the premise that these are individuals that walk into our clinics and actually say they're open to at least having the conversation about having their vaccine. Whereas we know in marginalized communities, the last place you want to be is in a doctor's office or a nurse's office. So I want to build the ball about what are the efforts, the concrete actions we take to start to make some penetrance into communities that are not just hesitant to take the vaccine, but hesitant to interact with the public health system and also the medical community. How would you take this on? So Reed,
well, I think I think the first thing we got to remember is that the decisions for the allocation of this of the vaccine are important for all health physicians of professionals of color to be attentive to. I was privileged to serve on the National Academy of Medicine committee that made the first round of allocation framework design. That work was then handed over to the ACIP team at CDC, advisory group to CDC. And then from that, that will then ultimately be passed down as from the CDC to the states. The states are not required or obligated to follow any of the national guidance. So they will do what they're going to do. And so the decisions at the state level will be key. And I think that we need to be assured that we are advocating for fair and equitable dissemination in our communities. So, for example, the use of pharmacies that will be so much a part of the federal strategy. Will those pharmacies be the right solution for our communities? Are there pharmacies in our community? Is it going to, the use of pharmacies going to disintermediate the medical home for the patient? And so will we be sort of cut out as our physicians? These are going to be very important kinds of things that we're going to have to pay attention to. Additionally, most of the allocation framework criteria do have a special higher priority, not the highest, but a high priority for people with 2 or more chronic illnesses. How will those people be identified? What will be the outreach to bring those people forward into the system? And so it will be our clinical records and our ability to touch and engage people who are at high eligibility for the vaccines that will be our responsibility. And finally, and lastly, is that I think that we're going to have to be very attentive at the local and state level to politicians who want to see their success quantified by the number of doses administered over a particular period of time. If reaching marginalized communities is going to be tougher than reaching other communities, we have to make sure that in the need for looking good on reports and being able to have press conferences about success, that they don't make decisions that will cut us out vis-a-vis the easier, lower hanging fruit. So these are all at least going in things that I think that we have a responsibility for as the trusted advocate for our patients and our communities.
Dr. Andrusek, some thoughts about how to reach folks that are really not part of our healthcare system?
Mhm. Well, again, I would go back to the trusted voices, the Indian Health Services, certainly for our tribal indigenous brothers and sisters. I think that many people depend on local pharmacies for these kinds of services. So ensuring that is a venue that individuals can utilize. And really, looking at some of the successful programs in the past that have been implemented in this country at the county and state level that have been really successful at reaching out to communities of color. New York State, I was talking to Dr. Fullilove at Columbia University about some of the efforts that New York State has done in the past that have been incredibly successful at reaching low-income families who are disproportionately represented by people of color in New York State, particularly in the 5 boroughs of New York City. So, for many of these states, there are programs that have demonstrated effectiveness. And so utilize effectiveness specifically in reaching marginalized communities, low-income communities, communities of color. So, I would, not reinvent the wheel and use some of these existing infrastructures and strategies to ensure equitable distribution and dissemination.
Great. Dr. Kanaya, anything to add to about strategy?
Yeah, I think this is an opportunity for us to think out of the box. I think, in the initial rollout, you're right, in the, early phases when we have very limited numbers of vaccines, we have to use healthcare centers, clinics, federally qualified health centers to, come up with lists of patients who qualify in the early rollout. But as we have more and more vaccine come online and more availability, we need to reach communities of color in their community where they live, work, play, and worship. And that means we have to think differently about how this vaccine is going to be disseminated, how the information gets disseminated, how the vaccine is given. Healthcare may not be the right answer for a majority of some of these communities. And we have to think a little differently about this. And working, of course, with community organizations, like Michelle said, is the right thing and the low-hanging fruit here to do. because they already have trusted, established relationships. But what about fire departments? People have more trust in fire departments than they do in their police. And would that be another way of disseminating information as well as getting out vaccines to people in every community? Fire departments are actually equitably placed in communities. So this is actually an idea that I heard because the California Vaccine Commission is talking about, using fire departments as ways to roll out vaccine in greater numbers in all communities. So, thinking a little bit more out of the box and a little bit more broadly about how we reach people in the places where they live.
So this is fascinating as well. And I want to start my last round of questions for you three relative to Dr. Kanaya encouraging us to think outside the box. Because I have heard that maybe the vaccine should be dispensed in community-based settings, such as community centers, maybe even libraries for that matter. But having said that, what is the role of technology to make sure that we know who got what, when they got it, if they're up to date, and also the intersection between technology and privacy and trust with our communities of color? Reed, since you served on that committee, do you have any thoughts about that and whether the committee thought about those issues?
Well, it is clearly an important point that you raise, and what I am concerned about is that we are facing now the challenge that we have been so slow and have failed so suboptimally to integrate our digital data systems. The relationship between our individual office electronic medical records, when and where they exist, with our public health infrastructure in many of our states is unfortunately suboptimal. And so this is going to teach us again the lesson that we really need to be able to do better. I am informed from just reading some of the reports coming out of Warp Speed that there may be some good software that is going to be applied, and that there is a effort now clearly underway to connect public health databases with the overall monitoring of the vaccine system. And we also are being made aware that there is a system in place, or at least being proposed, that will help to track this more effectively. But the proof is going to be in the pudding, and I'd like to see a little bit more about that. And so I don't think that any of us are in a position to speak authoritatively that the design of what has been designed is going to actually be implementable in real life. So what will happen I think to be determined. But I think the one thing that this ought to do for all of us now is to rapidly move us forward for integrated electronic systems that cross barriers from individual offices, individual medical groups, individual hospitals, into a much more public system. And as far as your very important caution around privacy and confidentiality, those would be issues. They are issues that are with us today across healthcare. They are issues that will be with us tomorrow, but we certainly should not and cannot let just that concern stymie our ability to move forward simultaneously with solving the confidentiality issues, but also we have got to get these systems interconnected.
Dr. Andrusek, any comments about technology and privacy, trust?
I don't know if I have much to say about technology. I sort of want to build on what Dr. Kanaya was saying about thinking outside of the box. And, I think one of the important challenges that we have is really our lack of success at bundling care and really identifying, services that we can provide together, including healthcare, mental health. When you go into a doctor, it's normal to have your blood pressure checked and your temperature taken. And what would it look like if we would bundle more services together and normalize that when you go in to care. You get, things like HIV testing along with everything else. And what would that look like if we provided spaces where individuals can have multiple needs met, including their healthcare needs and vaccinations, and we don't have that infrastructure at the moment, and we are very siloed in what we do in health and mental health and other services that our communities are in need of.
Thank you. Dr. Kanaya, any other thoughts?
No, I mean, I think many other countries that have a national healthcare system are going to do much better than we are. I think we're going to struggle. And I mean, this is a great opportunity for us to build something stronger and better. I just, at this point, I need to see it and believe in it. And I truly, truly hope that we do make efforts to have a more linked healthcare system so that we can know who is getting the vaccine, but not only getting the vaccine appropriately, but following them for long-term outcomes, because we do need these data to know, when you need a second shot, or when do we need a booster, or are there other, possible outcomes that haven't been seen yet in the first 6 months of these trials.
And also important, Alka, is the need for post-monitoring surveillance, post-marketing surveillance. So as these are out there in the land, we as health professionals will have a very fundamental role in being able to track untoward events long term. And that is a key obligation, responsibility that I'm sure that we all embrace.
So thank you, panelists. This has been a very interesting and meaningful discussion. We're at about the end of our time together. I wanted to ask each of you to maybe spend a minute or two for any closing comments before I invite our last commentator, who is Dr. Elena Rios. So, Reed, you want to kick us off with some last minute thoughts?
I think that this is our moment for ascendancy of our health professional leadership and our health professional practitioners. This is the moment where everything changes. The consequences of failure are so great. The variables are so complex. The need for expertise and connectivity to communities who are disproportionately suffering from this pandemic is essential. Our role is unequivocally essential. How we rise to meet this historical moment will say an awful lot about who we are and who we will be. And I think ultimately the deficiencies that we are confronting, the obstacles that we must overcome, those will be, I'm sure, the focus of exceedingly intense advocacy as we go forward and use this pandemic as an opportunity to make the changes that we've been trying to make and that this country should have made for generations.
Thank you, Dr. Tuckson. Dr. Andrusek?
I would just add to what Dr. Tuckson said, and as communities, we are stronger together. Our collective voices to move these actions forward is critical. And so we are, I am so thrilled to see the increase in collaboration among our communities and the increased efforts to move the needle forward for all of our communities in this pandemic. And like Reed says, I think we have an opportunity here for critical social movement, and it really has been great to see all of our communities working together and not as siloed as we usually are.
Thank you. And Dr. Kanaya?
Yeah, well, they took some of my points, but I'm gonna add another point. And I think, this pandemic has exposed a lot of social issues that we have in this country, made it wide and very clear that, yes, there's major inequities. And I think that the other, thing that this pandemic has exposed or has made clear is, as a scientific community, we can work together at very fast speeds to come up with solutions. And so I agree completely with Dr. Tuxen that this is our chance to work together as a healthcare community to bring in our patients and our communities to get vaccinated, to get early treatment if they have an infection, to really come together as one and have a collective voice in getting to herd immunity. And I'm really, really hopeful that we can continue to work together as this, group of a community together.
Well, thank you for your comments. I think we can say that with your voices and with the voices of all the audience, I think we'll make a good case for the kind of messages that we want to get out. It was very interesting to me that, just a few years ago, those of us in public health used to lament that public health doesn't get enough attention. And unfortunately, public health is like the headline and the middle of the newspaper and at the end of the newspaper, for better or for worse. But certainly, as you've seen, Dr. Kanaya, this is our time. Now I want to introduce Dr. Elena Rios, who is the president and CEO of the National Hispanic Medical Association, and invite her to provide some closing remarks and reflections.
Thank you, Winston, and thank you all for the event. I think it's been refreshing, optimistic. Let me just say that in a positive note. First, I want to say that diversity in vaccine clinical trials has really come up to the forefront. And I know it was mentioned that Moderna had 40% diverse subjects within their phase 3 clinical trial. I looked up the Pfizer clinical trial, which is the first vaccine that is up to bat, shall we say, on December 10th. The diversity is 42% overall, and Asian 5%. Black 10%, Hispanic 26%, Native American 1%. And they did a great job with the age of 56 to 85 of 41%. And that's the overall study. There's a slightly less numbers percent-wise in the United States, but I'm not going to read that. But I just have to say that I think it's an outstanding job from both Pfizer and Moderna, and I know that a lot of us were involved with helping to get the word out. So just a few comments overall. Dr. Winston Wong, Dr. Michelle Andrasik, Dr. Alka Kamaya, and Dr. Reed Tuxen. I think you are all leaders from your organizations and your research entities. I think that as leaders, you have brought to the forefront how important we are in history. This year, 2020, that some people would like to forget, is actually a year of a very impressive perfect storm that people have called it. The perfect storm of having Black Lives Matter come to the forefront with people of all races come together and understand that our most vulnerable communities need to be treated with more respect. And we have had a COVID-19 pandemic that hasn't been seen in our country for 100 years, this type of pandemic, and that it is a brand new virus with a lot of researchers able to come together and come up with some promising, I'll say the promising vaccines. And it is going to be up to us, the Latino, African American, Native American, Asian American communities of leaders to convince our patients, and we're talking mainly about physicians here, to convince our patients of the importance of taking the vaccine, not only to decrease the infection, but or the chronic disease caused by the infection, I should say, but to decrease the transmission to others in our families. And we are the backbone of the economy of the United States. We are the agricultural workers, the food industry workers, the essential workers in the hospitals and in the clinics, the caregivers for our families, and I could go on and on and on, but the minority people in this country, people of color, which was the theme of this event, how to convince the people of color who have been disrespected for years, marginalized, not given proper education, not given proper information about having healthy lifestyles, not to mention all the environmental, social justice that needs to happen, that we need leadership within the public health departments at the federal level and the state level and the local level in the distribution of the vaccines that's about to take place, assuming that the vaccines do get approved by FDA next week and the week after. Pfizer's up to bat next week. Moderna's up to bat the following week. And as we all know, at this point, there's about 6 vaccines that are going to be coming out, but the distribution and the allocation is really a matter of trust, that there needs to be trust. And the trusted voices in our community are us, the physicians. And I have to give a big plug for the Alliance for Multicultural Physicians, who were invited to come together and invite some of our guests tonight. And I'm sorry that a few of the guests that were invited were not able to make it, but we do have an alliance, which is more of a coalition of our major minority medical associations, the National Medical Association, the Association of American Indian Physicians, the National Hispanic Medical Association, the Association of Black Cardiologists, and CAPIP, the National Council of Pacific Islander and Asian American Physicians. So I just want to say thank you to the COVID-19 Prevention Network for hosting the event. I think the other major message, besides that we are the trusted voices and need to educate our communities, is that we're in this for the long haul. We need to change the dynamic in this country to be respected, to be leaders. And the only way to do that is to show, and I'm going to say, Dr. Tuckson, you're right on in saying we need to have a directory to show everyone that we do have leadership positions among our organizations. We do have leaders within the public health departments. We just need to connect the dots and start hiring even more in middle management that can move up and hire those for the next generation. And we all have students of research that are interested in research. All of our organizations have students that are interested in leadership. We need more leadership development to build the trusted voices for our communities to become a part of the important clinical studies that need to continue, the research that needs to continue, and most of all, to get the COVID-19 vaccines and to continue getting information on how to live more healthier lifestyles. I think that's the major message tonight. So thank you very much, and please go to preventcovid.org for more information about the COVID-19 vaccines and this wonderful network of researchers who's helping us with COVID-19 in our communities. Thank you.
And thank you, Dr. Rios, for those important remarks and your support for our communities and for the Alliance of Multicultural Physicians. I want to thank our panelists again, Dr. Michelle Andrusek, Dr. Alka Kanaya, Dr. Reed Tuckson, Dr. Lonnie Nelson, and Dr. Fabian Sandoval were unable to make it probably because of technological issues, and that's par for the course given where we are today. But I also wanted to thank blackdoc.org, as well as the COP Institute, and certainly the COVID Prevention Network for your support of this particular webinar and panel discussion. Be safe, everyone. Fight for our communities, and let's look forward to a future where we can get rid of this terrible pandemic that's devastating our communities. thank you for your work and your champion work of making sure that our communities are safe. Good night.